Good evening and welcome. My name is Roxanne Chabot from RBC Consultants. Welcome to another IDEF International Dermatology Education Foundation Educational Series Webinar. This evening, we're going to talk about ZORYVE, but a new indication for ZORYVE. And our moderator this evening is Dr. James Del Rosso, who is Research Director, Principal Investigator at JDR Dermatology Research in Las Vegas, Senior Vice President of Clinical Research and Strategic Development, Advanced Dermatology and Cosmetic Surgery in Maitland, Florida, and President of the American Acne and Rosacea Society. Our speaker this evening is Dr. Ashish Bhatia, who is Associate Professor of Clinical Dermatology at Northwestern University, Feinberg School of Medicine in Chicago, Illinois, and co-founder, Director of Clinical Research, co-director of Dermatologic Laser and Cosmetic Surgery in Oak Dermatology at the Itasca Joliet in Naperville, Illinois. We'd like to thank our supporters, Arcutis, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you'd like to submit questions to our faculty, please submit the questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in the browser and will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill them in and send it back to us. And within 1 to 2 days, a certificate of attendance would also be sent to you. Again, if you want to write some questions in the question chat pane on the right-hand side of your screen, I wrote a little note there so you can know exactly where to write in your questions. So we'd like to talk to you a little bit about the International Dermatology Education Foundation, who the president is Dr. Leon Kircik, who is clinical professor of dermatology at the Icahn School of Medicine in Mount Sinai, New York, adjunct clinical professor of dermatology at the Indiana University School of in Indianapolis, and medical director of physician skincare, DermResearch, and skin sciences. So the International Dermatology Education Foundation, whose principal mission is to raise awareness and improve dermatological care all over the world through education, especially in underserved areas. We've done many, many webinars since the pandemic, and this is some of the webinars. And you can also follow us on these handles, as well as go to our website at idefeducationalseries.com to register for any upcoming events, and also to give us your email if you want to receive invitations for future events. So without further ado, I'll pass the floor virtually to Dr. Del Rosso.
Thanks a lot, Roxanne. It's certainly a pleasure to be here to inform everybody. Roxanne gave me a very nice introduction, and I'm the stunt double filling in for Leon Kircik, who is usually the one that is running these seminars, but he was not available tonight. But I was actually very happy when I was told who our presenter is going to be. I've known Ashish Bhatia for quite some time. Not only is he very bright in dermatology, medical dermatology, surgical dermatology. If you have a question about lasers, whatever area of dermatology Ashish has been involved in, and he's willing to help anybody. He's willing to share the information he has, and he's just a great guy. So Ashish, it's great to have you here tonight talking about a new indication for topical roflumilast. Welcome.
Thank you, Dr. Del Rosso. Thank you, Roxanne, for having me tonight. I'm really excited. I'm glad to be here with you. And, you know, I learned so much from you over the years, and it's going to be great to share the virtual stage here with you and kind of talk a little bit about what's been going on with the new roflumilast indication. So let's kick it off, shall we?
Let's kick it off. Let's go.
All right, let's do it. So, all right. So we're going to be talking about ZORYVE. So ZORYVE's a once daily steroid-free drug, and you know it's a really great topical addition to our armamentarium when we're talking about atopic dermatitis, sebderm, and psoriasis. So that's what we're going to go through today. I just wanted to make sure everybody knew this is a promotional program. It's sponsored by Arcutis, and the speakers are compensated and are presenting on behalf of Arcutis. So, and we're going to do this in an FDA compliant fashion. So, all right. So, you know, safety information, you know, we always want to call out some of the things that you really do want to watch out with, even with a topical medication. So one of the contraindications for ZORYVE is, people with moderate to severe liver impairment, the child pug, B or C. So that's important to know. The other, which is just something you should know, is that ZORYVE foam is actually flammable, and I've lit it on fire. So it's actually a fun party trick. But be careful. Let patients know that if they're applying it, probably don't light up your cigarette right afterwards. So.
Yeah, it's the propellant that's within the formulation. So it's only when they're actively releasing the propellant from the canister,
Yep.
not an hour later if they put it on and they're
Yeah.
smoking a cigarette or something like that. Right?
Yeah, it's only for a few moments, but it's a good party trick. So, but keep it away from people. So, and then the adverse reactions, with these, they're really minimal. Less than 3%, and most were not even related to drug. But we do record all these in any clinical trial we do, and so it is important to know what they are with each one of these drugs. So they're listed here, and you can find that in the PI for every one of these drugs. So. All right, so let's talk about kind of the ZORYVE family, and there's three formulations that are out there, and they really cover the three major inflammatory dermatoses that we take care of as dermatologists. So plaque psoriasis, so that was the first approval in 2022, and approved down to age 6, and that's the cream, the 0.3% cream, which is approved for plaque psoriasis, including the intertriginous areas, adults and peds down to 6. The next one, the foam, which is one of my favorites, is for sebderm, and we really haven't had anything revolutionary for sebderm in a long time. So this has been a game changer. It's a 0.3% foam indicated for treatment of sebderm in adults and kids down to 9 in all body locations, which is amazing. And then finally, now we have atopic dermatitis using the 0.15% ZORYVE cream, and this is approved also down to age 6.
So one of the things I point out there is for the plaque psoriasis and the seborrheic dermatitis, the approval does not limit by the severity of the disease, right? And
Yeah,
none of these
absolutely.
limit by the area of involvement. It doesn't say only on the face, only on the trunk, and so the plaque psoriasis and seborrheic dermatitis is inclusive of mild, moderate, and severe. The seborrheic dermatitis and plaque psoriasis are for any severity. The atopic dermatitis does specify mild to moderate and is obviously the lower strength, and I'm sure you'll be getting into that. But I think that's an important distinction. You don't have any limitation, even on the body locations. As you mentioned, the seborrheic dermatitis, the studies included patients treating all the body locations. Well, when we look at the few agents that we have for seborrheic dermatitis, which a lot of them have been shampoos focusing on the scalp, and people have seborrheic dermatitis in other locations, this is the only agent that was evaluated to treat all the locations that are involved in the study. So I think that was important that you pointed that out.
It's key for patients, right? They love that because they're like, hey, what about this? What about this? Hey, put it wherever you have it, because
Exactly.
it will help, and it's been studied. So
Right.
I love that. So as Dr. Del Rosso mentioned, you can use it anywhere, and it's just a once daily application, which is really nice. So no restrictions on body surface area, and it is used for long-term disease control. It's not something that I tell patients to just use intermittently. Just use it because and we'll talk about this. There's continuing disease even in atopic dermatitis. When you don't see disease, there's actually disease there. So getting good control and maintaining control with a safe, effective drug is really nice. And it's consistently well tolerated. No steroids, so you can use it, eyelids and other areas where we want to avoid steroids. And it's affordable. They have an access support program, which we'll talk about as well.
And your point is so well taken. If we were giving a patient a topical corticosteroid, yeah, we can clear these diseases, but we're certainly concerned if they keep using it. We're here for patients not quite sure, is it gone, not gone, and they're continuing to use it. I don't care if they put this on every day. It's not going to hurt them. That's the bottom
The other
line.
thing I think another thing parents especially like is we don't have to talk about any black box warning here. So like some of the other drugs too. So that's another, I think, game changer, having a non-steroid without a black box warning. So well, let's talk a little bit about the mechanism of action, right? So these are all PDE4 inhibitors, and PDE4 is a molecule which really is elevated in inflammatory diseases. And what roflumilast does is it has a high binding affinity to this. And Dr. Del Rosso is a pharmacist and dermatologist, and so he knows way more about this than I do. So I feel silly talking about it in front of him.
Don't feel silly. I'm learning. I'm learning.
But feel free to jump in. So, what happens is with roflumilast or ZORYVE, it really binds well to PDE4, and like I said, in inflammatory conditions, this is all revved up, and so when you bind to it, it blocks that conversion from CAMP to 5-AMP, and what happens then is CAMP builds up, right? And there we go, slides are advancing, so you can see that here. And when you have an increase intracellularly of cyclic AMP, what happens is it downregulates all the pro-inflammatory cytokines, and at the same time, upregulates all the anti-inflammatory cytokines. On top of that, it also downregulates sensory nerve activity. And so that's where it really ends up helping with the itch as well. So this is really remarkable. Dr. Del Rosso, any
Yeah, I think the important thing to recognize is this is happening intracellularly. This is a physiologic mechanism that's keeping inflammation in balance. But when you have a disease with dysregulation, you have too much of it. So really all you're trying to do is turn that volume knob down and suppress that activity within the cells. So that's sort of the way I look at it.
Yeah, it's really just modulating all that,
Right.
for going from an inflammatory to an anti-inflammatory, which is great. So it was really intentionally designed, and I think Dr. Rosso and I both have had the opportunity to meet the brilliant scientists that formulated this, and it was done very intentionally. So it has moisturizing properties, no known sensitizers or irritants like propylene glycol or isopropyl alcohol or ethanol. And it's really designed to be easy to use. And then the trials were done actually testing it that way. So it's once daily, no steroid, non-greasy. It spreads really easily. And it's surprising you don't really even need a lot. It really a little bit goes a long way. The foam for seborrheic dermatitis goes even further. Plus, it's really nice to use in the hair-bearing and non-hair-bearing areas. It actually preferentially goes to the skin and actually avoids the hair. So you don't have that as much residue and stuff on the hair. Any insights? Because I know you
Yeah.
were probably involved in some of the formulation.
I consider the formulation to be the secret sauce. And when you look at the formulation, regardless of whether it's atopic dermatitis, plaque psoriasis, seborrheic dermatitis, the tolerability has been extremely favorable because of how they formulated this and looking at what's not in it. But roflumilast is not very easy to solubilize. So without getting into the weeds of what they actually utilize, they utilize components that are not typically utilized in a lot of formulations. That's why a lot of other formulations that we have, they're throwing in a lot of lipid, they're greasy, they're hard to wash out of the scalp. This was specifically designed to be able to avoid that. Plus, one of the major components partitions the roflumilast, so it actually is held where it needs to be in the epidermis and to some degree in the dermis, and is delivered very slowly. So that's why you get very little systemic exposure. So it's not a buzz phrase. There's science and good science that people at the company can provide for you that this is really an extremely well-designed formulation, the way Dr. Bhatia mentioned. So one of the things I wanted to ask you, Ashish, is I make sure I tell patients it's not a corticosteroid, because they've been used to getting different treatments, different medications, and I may be thinking something but not relating it to them. And they might be thinking you're just giving them another topical cortisone. So I try to make sure this is not the same as what you've used before. How do you handle that?
No, great point. I tell them the same thing. I tell them this is very different than anything you've used before, and it's really specifically designed to be gentle on your skin, doesn't strip away anything. It's not a steroid, so you don't have the safety issues there. And I want you to use it, and I want you to use it consistently. And it really doesn't have any burning, stinging in most people as well. So because it's formulated at physiological pH. So I tell them all these things, and just tell them that it's going to be easy to use and comfortable to use, and very different than anything you've used before. It's nice too, because it's not a generic, so you know exactly what's in the vehicle and how it's going to perform,
Yeah,
which is
you
nice.
have the other thing, the only difference really between the foam and the cream is the foam is about 65% water and the cream is about 50% water. So that's really the only difference between the two, right?
Ah, fantastic.
Yeah.
Well, let's talk a little bit about ZORYVE for atopic dermatitis. So this is the 0.15% cream, and atopic dermatitis, as we all know, especially going into the fall here, you see this flaring like crazy, right? There's 26.1 million people in the US that live with this. And it's surprising, this statistic, 1 in 3 days of their lifetime are spent in flare. That's a lot. So it really affects people tremendously. And I had atopic dermatitis as a kid, and I still get flares. So I'm really sensitive to this. And itch was my main concern too, and it's surprising how much impact it has on people's lives, and we all know this because we see this every day in our practice. So, 2 in 3 patients are not happy with the treatments that they have now because they're not getting good control. What do we tell most patients? Skin care, avoid hot water, all these things, apply emollients. But, even with all that, there's a lot of people that just continue to flare. And so they spend a lot of their time. I thought this was a surprising statistic. More than half of patients reported spending more than 5 hours a week managing atopic derm. What do you think about that?
Yeah, I mean, it really doesn't surprise because, we
Yeah.
see people at snapshots of time on the days they come in, but they're living
Mm-hmm.
with this every day. Not only do they have the itch, the trouble sleeping, everybody's
Mm-hmm.
irritable, kids get bullied at school, nobody
Yeah.
likes to be, you're giving a presentation right now and you have an itch that you're dying to scratch, and sometimes in some
Yeah.
very embarrassing locations, quite frankly. So it
Yeah.
bothers people in more ways than sometimes we're thinking about the patient. What are we going to give them? Are we going to be able to
Yeah.
get it approved? But there's so much more that's going on in their head, right?
Absolutely. And a big part of this is just this epidermal barrier dysfunction that happens. And it's really present even on non-lesional skin. And so that's why it is important to just treat very proactively and treat the areas even where people just have itch, but you don't see any visible lesions. This is the whole kind of the immunological sectors of the skin and what's going on. So, you don't want to let it get to the point where the skin barrier breaks down. You really want to kind of, anywhere you have itch, you probably have in the disease process because that's that inflammation going on.
It,
Agree, Dr.
I
Del Rosso?
Yeah, I mean, I trained back when dinosaurs roamed the earth, and I remember them telling us that it's the itch that rashes. I never understood that. You gave them antihistamines, all it did is make them sleep. It really didn't help the itching very much. Now we understand why. You know,
Yeah, yeah,
we didn't have the word cytokines or
yeah.
Th2 inflammation back then, but now we understand why it's the itch that rashes. So what you say is so important.
That's a really good point. Yeah, I forgot about that. That's how I first learned about it too. The itch that rashes.
The itch that
So
rashes.
true. So true. So this is the pivotal trial that was done. It's a two identical trials, multi-center randomized. They were called the Integument-1 and Integument-2 trials. And Dr. Del Rosso, you did these trials. If you want to talk about kind of the key points here, I would love
Well,
that.
well, I think one of the things that's really important, you're talking about a 4-week study, right?
Yeah.
They're they're looking at what this agent is doing in the pivotal trials, and obviously everybody's blinded. Nobody knows exactly what they're getting. The patient,
Mm-hmm.
the researchers, the staff. They're looking at what this is going to do within 4 weeks. So they had to be mild or moderate atopic dermatitis. So
Mm-hmm.
they had that global assessment of equal to 2 or 3, of
Mm-hmm.
validated visual global assessment, easy score of at least 5. That's the eczema area severity index, and they had at least 3% body surface area. But as you'll see, it was actually a lot more than that in the trial, and a significant number of patients that are at least 6 years of age. So really what you're looking at is clear or almost clear, with at least a 2-grade improvement by week 4, which means that the mild had to get completely clear, no pink, no sign
Yeah.
of inflammation. And then obviously they're looking at those secondary assessments. But there's a large number of patients in the trial, and the
Yeah.
vehicle is lower. Obviously, you
Hmm.
want as many patients to get the active drug, but you have to
Hmm.
have enough in the vehicle group for the statisticians to be able to show you the statistically significant difference, which fortunately was in the study. So it was a well-designed study, but 4 weeks and
Yeah.
monotherapy, no other therapies. The moisturizer and emollients had to be minimal, and they were allowed on. They were not allowed on the treatment sites. That's important. So they
Hmm.
couldn't use the moisturizers on the areas where they had the visible eczema during this component of the study, right?
Yeah. Yep. And then everybody was washed out if they were on anything else, and biologics had
Absolutely.
to be washed out over 6 months. So
Right.
it was a true kind of head-to-head vehicle to drug and vehicle study, which is
But 4
great.
weeks is a compressed time to be looking at the efficacy of a drug, right?
Absolutely. These are very short trials. You're right. And yeah, here's the kind of the mix. There's very diverse population here, ages all the way from 6 to 91, right? Which you don't see that too much, trials going all the way to 91. And yeah, pediatric adults both were represented, and lighter and darker skin types were represented. So this is a really good study. I like the fact that some of the people, like you were saying, it was a lot more than 3% BSA, up to 88%. That's some severe atopic dermatitis when
So
you get to
so
88%.
so the average was 14%. That means
Mm,
whatever the size of that hand, the
mm-hmm.
palmar surface of the hand on that patient is 1%. That means that 14 times that was what was on that patient's body when they presented. That's a significant amount of atopic dermatitis. Enough where that might be enough in other types of studies where they're looking at systemic agents for those patients to receive a systemic agent for their atopic. Obviously, I'm not making that comparison at all, but it is a
Sure.
significant amount of atopic dermatitis, right?
Absolutely. Absolutely. So let's take a look at the skin clearance that people achieved at week 4. Um, so this chart actually shows the skin improvement at week 1, week 2, and week 4. And on the left, you can see those who achieved IGA, atopic derm success, and on the right, you see the people that got down to clear and almost clear. So what do you think about these results here?
What I think is really important is to recognize that it marches up very quickly, right? Obviously, you're looking at clear or almost clear with at least a 2-grade improvement, right, in these patients, clear or almost clear, but it marches up very quickly within 4 weeks. So, yeah, but remember that the vehicle, it's you don't want to see the vehicle not have an effect. It's very
Hmm.
important to be looking at this vehicle providing some benefit. So you might say that, you have 14% in one study and 21.4% in another study. That's a good thing. In fact, looking at this vehicle, it actually was compared to a ceramide-based moisturizer in a report that was just published. And achieved the same moisturization parameter. So again, you're not looking at using it as a moisturizer, but you certainly don't want to use an agent that's going to impair the barrier, which actually topical corticosteroids do once they're discontinued. So
Hmm.
seeing that vehicle effect is good. You don't want to have a lousy vehicle, but seeing the substantial difference with the roflumilast being there, uh, I think these are very impressive results, especially within 4 weeks.
I know, and some of these people, as soon as 1 week, you start seeing significant improvement.
Right,
So that's impressive to me.
right.
And these people are dying for relief, so this the sooner the better, right? So
Exactly, exactly.
yeah. Well, let's take a look at some pictures, right? The neck, this person is 51-year-old male, a lighter skin type, and you can see he started with a score of 3. In 1 week, he was down to 2, so you're starting to see improvement. And patients like that, right? That increases compliance. You start seeing effect immediately, even a little bit. That's encouraging. And then at week 4, they're down to a score of 1. Let's take a look. So let's talk about the itch, right? Because itch is the main symptom, and it's the one, at least for me, it drove me nuts, right? The itchiness. Um, So you got 2 times greater itch improvement with this, compared to vehicle, and it's a very nice vehicle too. You know, it's a emollient vehicle. You can tell us a little bit about just the vehicle. I mean,
Right.
it's
Well, you
probably one
know,
of the best
when
designed ones.
when we use a well-formulated moisturizer, and we've even
Hmm.
had some prescription agents that are glorified, barrier repair agents, the patients improve and get some improvement in itch. Not enough to be that that's the only thing you're going to use, but you want to
Hmm.
see that pattern. And with
You
the
do.
vehicle doing that, that's a
Hmm.
very positive thing. And
I
then
love it.
seeing the advanced benefit of having the
Hmm.
active ingredient in there. You got to
Hmm.
remember, roflumilast is more potent than other PDE4 inhibitors that we have available in the market because it has more binding sites on the
Binding.
PDE4. Uh, but you want that within the skin. You don't want that systemically, right? Because then
Yes.
you get into the issues of GI tract and all that, which
Hmm.
fortunately is negligible, pretty negligible with these drugs for every indication. But you want
Hmm.
that effect within the skin. So you want to see that difference, but you like that the vehicle group is contributing to the benefit. So
Absolutely.
it's 2 in 1. You're getting both
Yeah.
benefits.
Yeah. And the other thing really cool here is that even at day 1, you could see the improvement. So within 24 hours, patients saw improvement in the drug over the vehicle, which just shows you how quickly it starts working. So, it's working by a very, very clean mechanism too, which I really like. So here's a darker skin patient, 15 years old male. This is a common area for atopic dermatitis. You see people scratching themselves to death. And same thing, baseline had a score of 3 down in 1 week down to a 2, which is great. The earlier things start working, better the compliance, and then week 4 down to a score of 1.
So Ashish,
All right.
if we can go back, look
Yes,
back.
sir.
I mean, I think this is the kind of patient, the darker skin individual, where it becomes a
Hmm.
little bit harder. I was fortunate practicing in Fort Lauderdale, and my trainer made sure that we saw all kinds of skin types. We had a very diverse population down there close to Miami. I saw many
Hmm.
different types of skin colors. So I got used to what inflammation looked like in darker skin, but it becomes tough. It would be that because of the residual hyperpigmentation and not really able to tell if there's any erythema in there at all, it would be hard to call that week 4 patient completely clear. And that makes
Yeah.
it difficult,
True.
correct? Do you run into that?
100%, yeah. And darker skin types, it's very tough to see. But the one thing we do and see the improvement in is that ashiness of the skin,
Yes, yes.
and that's surprisingly that's what my Indian patients and African American patients really, that's what bothers them the most. They could care less about the little bit of redness.
Yeah, they can't really see the redness, but if you're not
They
used
can.
to looking for those, I mean,
Hmm.
it would even affect someone with your skin type. Indians,
100%.
Middle Eastern,
Oh
Asian,
yeah.
a lot of different kinds of
Hmm.
people can have that. But the disease is still there and it's still bothering them, so you got to treat it,
Yep.
right?
And that's why I tell them to continue the therapy as well,
Yeah.
because sometimes you get, like you said, in these skin types, you can't see that little bit of residual inflammation. So,
And if you were using a corticosteroid there, you'd be
hmm.
concerned about
um,
residual hypopigmentation potentially, but
yes.
you're not concerned about that with this particular agent, right?
And for some reason, like in these younger, the 15-year-old teenagers, I end up, the ones that have overused steroid in that area, I see a lot more stria too,
Yep.
and some other manifestations. So yeah, great points. So let's talk a little bit about the EZ75 score. Is this kind of what you saw when the study, when you did it
Well,
too in your
well, you
patients?
well, easy scores, they're a little bit, more challenging, and when you have
Mm.
lower, you're looking at a lower body surface area, so they typically come in with, the systemic agents, but you still
Hmm.
want to make sure that patients, whatever areas are involved, and here you're looking at 14%, so it can still be pretty significant, the body surface area. You're
Hmm.
looking at any easy improvement 90%. So patients are noticing something. Then you get to easy 50, which is still a pretty good result. It's not the bar
Hmm.
that we typically go after, but you have
Hmm.
70% of the patients having a 50% reduction, right? And the vehicle still once again contributing. Now you get to Easy 75, you almost have half of them by week
Yeah.
4 with an Easy 75. Then Easy 90 and Easy 100, you have 1 out of 10 patients completely clear within 4 weeks, and
Yeah.
2 out of 10 practically completely clear in 4 weeks. So it gives you a ballpark of where patients might fit in.
Yeah.
But even people that look like they're having a lesser response, if you think about it's only 4 weeks, they're seeing a big difference from where they were in the beginning. And they're good.
Yeah.
Most people are going to appreciate that.
For a non-systemic drug too.
Right.
So
So a
it's impressive.
non-systemic and a non-steroidal. Yeah. If I bomb them with clobetasol, but how long are they going to be able to use that? I mean,
Yeah.
it has a tendency to flare up pretty quickly when they have to stop it. So it takes away all that concern, and you're marching toward continued improvement. That's what I see in
Yep.
patients.
And talking about steroids, I really worry about using steroids on these delicate areas like on the eyelids and facial skin. So, here you can use it safely, and same thing, people within a week you can see improvement. Patients see improvement, and then week 4, we're down to a score of 1, which is great. So, well, let's talk a little bit about, the SCORAD, right? SCORAD has all these other components, and this really did affect the patient's quality of life. And you can see that in the SCORAD, especially in the pruritus, which we know because it's part of the mechanism of action is helping with the itch. But then it translates into improvement in sleep loss, right? Because I'll tell you that when I had flares, I mean, that kept you up at night, right? That's an issue, the itchiness and the scratching. And then it got raw. So, I mean, all of these things, like blood on the sheets and all that, no fun, but it really helped with that. And then the dryness of the skin. So, as you start calming down the inflammatory process, the skin actually has a chance to heal. And now you got nice emollients to help it. So it all plays part and parcel, and you can see it reflected in these quality of life index scores.
And what's so good about the fact that they use the SCORAD, the EASY score does not factor in patient-reported outcomes like, itching and sleep loss, right? You may see itching if you see excoriations or whatever, but here you're factoring in the patient-reported outcomes, and it could be trouble falling asleep and trouble staying asleep or being woken up, which is no fun, right? And
Yeah,
sometimes the
great.
person's asleep, but they're digging into their skin, and there is blood on the sheets. So
It's
the
true.
SCORAD is a nice parameter to look at in the study. It's not used enough.
Yeah, no. Having patient-reported outcomes is huge because it really corroborates the patient's story with what we see clinically. So
Exactly.
love that. Yeah. So let's talk a little bit about the adverse events, right? So we see this for every drug we study, right? The active plus the vehicle versus just the vehicle, and you can see they're fairly negligible, and less than 2 in 100% in 100 patients reported stinging or burning. And it was with vehicle as well. The vehicle was a little more actually than the ZORYVE itself. And there's very low rate of discontinuation. And why? Probably because it starts working quickly, right? So people don't stop. And it really doesn't have very many side effects. So can you talk a little bit about what you think about these treatment emergent adverse events?
So when you're looking at, treatment emergent adverse events is anything that happens in the study. Doesn't mean it was related to the drug or not, but obviously you're looking at, did it happen in the active versus the vehicle? And if you see a big jump in something, you're obviously wondering, hey, we need to look at this more closely. But that less than 2 in 100 with stinging and burning was consistent with all the indications. You'll see it's going to be the same with seborrheic dermatitis. And if you went back and looked at psoriasis, it really, so it is very low likelihood that patients are going to tell you about any local tolerability reaction. And rarely did you need to stop the drug, right?
That's great. Yeah. And this was consistent along all the age groups that were studied, and obviously non-steroids, so we don't have HPA access suppression issues, which is really nice to not have to worry about that. So looking at the patients, and first application, 10 to 15 minutes after application, we looked at people, and the tolerability of the medication versus the vehicle. And so what we see here is that the drug was extremely well tolerated. So most people had mild to none, over 90% after the first application. And then even out at week 4, now you're getting, because now you get the skin barrier repaired. And so you're getting 96% or 93.4%, and even in the vehicle, reporting mild or none sensation after the application. So that's something we worry about. There's been some drugs that have been launched that have a lot of stinging and burning, which, you know, it's not really great for kids with broken skin and AD. So it's really nice to see that this has such a tolerable profile. Only one patient discontinued the roflumilast in the study, and one patient also discontinued the vehicle. But that's pretty remarkable for a study with a size of 1377. So,
and the term application site pain is a term the FDA forces us to use, but they're not talking about pain like herpes zoster pain. They're talking about
yeah,
stinging, burning,
burning.
sensation. It bothered the patient enough that they discontinued. Fortunately,
Yeah.
only one patient. Okay.
So with like many studies, there was an open label extension that was done kind of looking out to 56 weeks, right? And just seeing if there's any safety signals, because you're repeatedly applying this drug for a longer period of time. And this is a good study to do because it gives us comfort that the patient can use it long term and not have any issues. And you know, this was a very clean open label extension study. Do you want to talk about this? I think you participated in this as well, right?
Yep. So what's interesting is it really didn't show anything else that came up that was different than what was seen up front. But you can
Mm-hmm.
see there on the bottom, 130 patients were switched to twice a week to see if that would maintain their control without having to apply every day. And they would use that on the areas that were previously affected, sort of a preemptive management. And a significant number of the patients were able to sustain the control of the disease. If they didn't, then you could go back to more frequent application. But that was that whole idea of intermittent chronic use, because it is a chronic disease and you're trying to reduce flares. So it
Mm-hmm.
does. That was a nice thing that they looked at.
Yeah, it's great. Very nice. And then they also looked at, you know, the improvement, right? The easy 75 achievement across the 56 weeks, and this even kept on going up, which is great. You see that patients continue to get improvement even in long term. So it's not like it kind of tapered off or went down, but it actually continued to go up a little bit.
So the line on the bottom are the people that were on the vehicle,
Vehicle.
and it
Yeah.
didn't take them very long to catch up. And once they caught up, what
Mm-hmm.
this shows is over time, going out to 56 weeks, a little bit more than a year, people could sustain their benefit. Now, maybe they may have stopped in some areas, but as long as they're continuing their treatment, they
Mm-hmm.
sustain their benefit. In fact, it even went up a little bit. But you
Yeah.
know, it doesn't stop working when you need to keep using it. It doesn't show any sign of what we always call tachyphylaxis. Right?
Yes. So in summary, you know, the ZORYVE cream, 0.15%, which is approved for atopic dermatitis, is really a once daily steroid-free cream that we can use for relief anywhere in the body. And you know, now it has long-term studies to show its efficacy and safety out to 56 weeks. So, and it's just very nice because, you know, in our patients, getting them to get itch relief and symptom relief quickly really helps with them to stay on it and then get that long-term success with it.
And if they happen
And
to not come back and they're doing well, you're not concerned about them having a problem, right? I mean,
exactly.
right.
Yeah, 100%. No, great point. So let's switch over to ZORYVE foam for sebderm. Like this is one of my favorites, right? Like for years, I've wanted something good for seborrheic dermatitis that really works and works for patients no matter where I want them to use it. And this really kind of fills that gap. So sebderm, it's super common. We see it all the time in our patients. 10 million patients in the US live with sebderm. And you know, itch can be a big problem with it, and you know, it's stigmatic. I mean, you've even seen in movies where people are like itching their scalp and all that kind of stuff, and it's usually, you know, it's usually negatively connotated. It's kind of like the rhinophyma is kind of connotated with alcoholism, the itch and sebderm is kind of stigmatized too. And
Ashish, what if
there's
you're wearing a black jacket? What if you had some flakes on your jacket and that's embarrassing. Let's face it.
it's
Nobody likes that.
nobody likes that. And yeah, it leads to ridicule for kids and all sorts of social issues. So most people, and I can attest to this, until we got ZORYVE, most people I think were not happy with their treatment. And these were time-intensive treatments, right? They're shampooing, they're applying creams. A lot of people come in that haven't been diagnosed that are moisturizing over and over again, thinking it's going to help. And they're just desperately trying to get rid of this red patchiness in their beard or their itchy scalp. So most people are very unsatisfied, and they're doing a lot to try to maintain it. Very few people, I think, don't care about it. There came along ZORYVE foam, right? And this is a once daily monotherapy trial that they did over 8 weeks, called Trial 203 and the Stratum trial. Once again, I'll let Dr. Del Rosso talk a little bit about the trial because he actually did them.
And
I'm going to turn the light back on and turn it off.
There were a couple of different trials here, and we'll see as we move on. But remember that all the areas that were involved, and it was close, I think about 3/4 of the patients had multiple areas involved. The scalp was the most common, but they can have the paranasal areas, they can have along the hairline, they can have intertriginous areas involved, they can have eyebrows, eyelids, and all the areas were evaluated. So when you get to clear or almost clear, all the areas treated had to respond. If, let's say, the scalp completely cleared, but they only got to mild in the paranasal area, they would not consider the success, even though what was most important to them, let's say, was improved. So this is the first time all the areas involved had to reach that primary endpoint. So that was a significant difference in this particular trial. Right?
It's a very unique trial in that way, I'd say. So, and once again, like you said, with the other trial, it's a 2-to-1 randomization. Two for every 2 people that got ZORYVE, 1% got vehicle, and that's for statistical reasons. And this once again was just monotherapy, so no moisturizer or emollients were allowed on the treated areas. So let's take a look at the areas. So you just mentioned this, right? Scalp was number 1. And then, the facial was the second most common area that was included in the trial. But then the ears, right? We see the ears all the time. But luckily, they did have some trunk and eyelids as well, because I do see it a lot in the eyebrows, eyelids, and on the chest.
Yep.
Yep. Yeah. So it was very representative. Nice age range, going from 9 to 87 years old, and all skin types were represented, and hair types as well. So. This is really, really a well done study.
And when you think about it, these people come in, they're using a shampoo for the scalp, and keep in mind that the shampoo agents and the agents that are used for seborrheic dermatitis have not every day, and they had limited durations in their package inserts. They have restrictions on them, and even the foam that we had of ketoconazole is very different than this foam. It had a lot of alcohol. It was not addressing the barrier. It was just addressing malassezia. And we know the disease is more than malassezia now. So some of these older agents, there is a foam, a ketoconazole, but it is not formulated anywhere near the same way. It's an alcohol-based foam. It's going to cause stinging and drying, and it's going to be negative to the skin barrier. So they might say, oh, there's another foam available. It is not the same at all.
That's a really good point. So let's take a look at the IGA success. So looking at week 2, as early as week 2, you start getting people who are getting down to clear or almost clear with a 2 or greater grade improvement. And then that continues at week 4, more people get that. And then at week 8, 77%, you're getting that. So
half the people are completely clear at week 8 in all the areas, not just, people had multiple areas and almost a little over 7 out of 10. All the areas are getting completely clear in order to make that statement.
Yeah. Well, let's take a look. So, you can see a little bit of that hypopigmentation on the hairline here, where this is a dark skinned patient with sebderm. And, this is impressive. At baseline, it was a grade 3. In week 2, it was down to a grade 0. And not only that, you see the improvement in the hypopigmentation. And by week 8, all that hypopigmentation is gone. So, just like we hear of post-inflammatory hyperpigmentation, there's post-inflammatory hypopigmentation in darker skin types, and we see that a lot. I see it in myself,
Mhm.
and people are really bothered by it. No, people don't. I find that Caucasians don't like dark spots, and dark people don't like white spots. So
Right.
we're really bothered by it,
I find the dark
and
people who don't like light or dark spots. Your acne
yeah.
patients are complaining more about what's left behind sometimes than the acne itself, right?
100%,
Right.
100%. So, yeah, it's really nice to be able to improve that cosmetically on top of taking care of the issue. Now, take a look at this person, right? 63-year-old female, bad sebderm, brows, glabellar area around the nose, perinasal. Oh, yeah, this is bad. So, and people are scratching this, and people are trying to rub it off all the time, and it just gets more inflamed. After 2 weeks, it's barely there. It's down to an IgA of 1, and then the erythema is almost gone by week 8. So, but more importantly, the symptoms are gone, and you don't have that flakiness and redness. I mean, this doesn't look good. People are very self-conscious of it.
And I would venture to say that some investigators would have called them clear at week 8, because
Hmm.
constitutionally, people with fair skin have a very low level
Background.
of erythema, and you wouldn't
Oh
know
yeah,
that because you didn't see them in the beginning. So
sure.
if that it's hard to tell in a
Yep,
picture because you're not right in front of them, but that
sure.
patient is as close to clear as you can get for not being clear.
Agreed. Yeah,
Right.
100%. So now let's talk about the itch improvement, right? That's the other part of it. 63% of patients experience itch relief at week 8. So that's impressive. And you can see the curves here. So the darker curve, the lower curve is the one for ZORYVE, and then the vehicle above it. And so you can see over time that itch goes down, but it goes down rapidly in those first couple weeks. You start seeing that decrease. So and that's important. Not even first couple weeks, sorry, first few 5 days, you can see quite a bit of an improvement. So it's a good slope early on,
Right.
which I like because that increases compliance.
Yeah, and I love the curve with the vehicle also, because we
Hmm.
now know from definitive studies that seborrheic dermatitis has skin barrier impairment, overlaps some with atopic dermatitis, but had some in and of itself. So we don't want shampoos or vehicles that are going to be damaging to the skin barrier, because the disease is not going to do as well, especially long term. So that vehicle component here is significant also in seborrheic dermatitis, not just atopic dermatitis.
Let's look at this 9-year-old girl, and here she's treating her scalp as well as the ear, and it's impressive the improvement. Now this was an IgA of 4, so this is severe, and in 2 weeks down to a 2, and then at 8 weeks down to 1. And this is impressive. I mean, you can see some bleeding in the scalp and erythema and crusting.
Some
This was
scratching.
this
Yeah.
was Yeah, a lot of scratching going on, and that having that be almost completely clear is remarkable.
And both, they may have been completely clear on the scalp, but if they weren't on the ear, they would have
Hmm.
gotten the rating based on the ear, because
Absolutely.
everything had to be the same to get to the endpoint. Right.
Great. You want to talk about the quality of life here? I mean, I
Well,
think this is impressive.
well, I'm waiting for the day that the DLQI is the dermatologist's life quality index, but I don't know that that's ever going to happen. So we're looking at, the bottom line is, if people are not itching, they're not scaling. If you actually look at some of the work that Raj Chivatia has done, reporting some of the patient-reported outcomes and actually querying patients in questionnaires, this bothers people more than we might perceive. A lot of times they
Hmm.
don't even bring it up, right?
Yep.
And so we can see here that I'm glad the vehicle improves it, but you're seeing that these patients have a significant improvement, and you can see on this that really the minimum index to try to achieve that benefit is 80% in the active and 60% in the vehicle, close to 60% in the vehicle. So these are very nice numbers for something like
Yeah,
atopic dermatitis.
absolutely. So just quickly here, the adverse reactions, once again, were very minimal. Nasopharyngitis, nausea, headaches, and not, there's some in the vehicle, a little bit in the drug. So, but once again, what Dr. Del Rosso mentioned before, less than 2 in 100 patients reported any burning or stinging. And once again, no atrophy, stria, dyspigmentation, any of those steroid issues, and fewer than 1% of patients discontinued the ZORYVE foam.
And the mean body surface area was about 3% in seborrheic dermatitis, so it's a lot lower area of application when you add it all up. Right?
Mm-hmm. Yeah, for sure. And then here, looking once again at the first application, the amount of stinging or burning anybody got, it was mild or none for most patients. And at week 8, it was almost negligible for most patients. So 98.9% of ZORYVE foam treated patients, 100% of vehicle treated patients had no evidence of irritation on the scale. So let's take a look at a picture. Okay, so this is the hypopigmentation we were talking about, right? So this was pretty consistent. This is a 35-year-old male with darker skin type and went from an IGA 4 to an IGA 0 at 8 weeks. But look at that improvement in the skin tone, right? It's even. And this is something patients like. They really, really appreciate. All right. So let's talk about the open label. Like with this one too, there was an open label study, and this went out 52 weeks. So if you want to hit the highlights here, that would be great.
So you had 2 different studies, and you're seeing there with the de novo. So there were some patients that had not been treated before, and then there were the patients that completed the study, 8 weeks of vehicle or ZORYVE foam every day, and then they were transferred over. And there was a 24-week period that they were evaluated. So everybody's getting the active drug. They're getting the ZORYVE foam 0.3% every day. And then when they got out to the week 24, you can see here a small number of those patients were continued on, because the reason why that happened was the decision was made later to go further than week 24 in this particular extension. And by the time that decision was made, some people had already completed, because they're starting and stopping into the study at different time points. At the point in time that they elected to look further, they were then able to capture those new entries going out the remaining 28 weeks to go to 52 weeks. It wasn't by any type of selection to try to create the actual results. I want to make that clear. And then you're looking at evaluate. The long-term extension is used primarily for safety, but you're able to capture efficacy. So that's why it was done this way.
Got it. Well, let's take a look at the results from that. So these are the IGA scores getting up to a clear or almost clear. And look at that. This is what you were talking about. Not only was the safety there, and tolerability, but the improvement was there as well. And you saw that got even better in that second half of the year. We achieved 80% of patients achieved clear or almost clear, which is very impressive.
I mean, there's a lot of things. People are getting used to using it. They're more facile on applying it over time, and the drug itself continues to add on efficacy as you continue to use it. So I think that's and some of them could starting and stopping. Some of them are continuing areas because they're not really sure, but it doesn't matter because you're not concerned about the safety of it.
Yeah, and none of the tachyphylaxis either, like you mentioned before.
Right.
So same thing. Yeah, good point. All right. So, regardless of hair type, this is actually designed to be used in the hair or beard areas, or even in the hairy chest or hairy back if you have one. And it's very easy to apply. You shake the can, you turn it all the way over, nozzle down, and then just take some out, and then you apply the foam on whatever area is affected. So very simple, very easy to use for any patient.
They recommend the palm of the hand because it's not a quick break foam like some of those old alcohol-based foams that they immediately liquefied. It will retain its shape. I actually like to do what many of us did in the study. We just fill it into about a third of the cap. That's going to be pretty much all they're going to need to cover the areas of involvement, and they don't waste it by continuing to spray out more and more, and they just dot it and apply it to the areas and massage it in very easily. That's the way I typically do it in practice.
Yeah, I tell them to be very conservative. Little goes a really long way.
Right.
So I love that idea of a third of
Yeah,
a cap.
if they hold that down, it's just going to keep mounding up, and that's where your staff, it's really important for them to make sure they know how to use it.
Yeah, great. So, all right. So there's some other studies being done, and the results from this will be coming soon, really looking at the patient journey and capturing their experience. So I'm excited to hear about that. That's going to be coming up. So, in summary, this is a very important drug for us because we really didn't have anything to fill this gap for the longest time. It's a very simple, easy to use treatment for seborrheic dermatitis control, and very good success at 8 weeks. And patients really got symptomatic relief on top of the relief of the actual visual part of this. And it's safe for all skin and hair types and can be used anywhere on the body or head or neck, which is pretty remarkable.
So, I think it's really important to, while we're waiting for some of the questions here to come in, let me see if we have any coming in. I have a few here, but make sure the diagnosis code correlates with the formulation you're using because of the way the indications are written. That may certainly change over time, but if you're writing the 0.15%, the patient has atopic dermatitis. If you're using the foam, they have seborrheic dermatitis. If you're using the 0.3% cream, it has a diagnosis consistent with psoriasis, to prevent those annoying faxes and pushback, which don't make a lot of sense, but we obviously have to deal with them. So we try to do that preemptively, even in the EMR, right? Let them know it's sensitive areas. They failed steroids or they've used steroids, and try to capture it up front. But Ashish, I have a question here, right?
Yeah.
So one of the individuals wants to know, can they treat more than one location for seborrheic dermatitis at the same time?
Yeah, good question. And luckily they did do the trial in a way which showed that you can safely and efficaciously treat multiple areas of the body. And some people even had, up to 70, 80% of their body surface area that they were treating. But, most people were treating smaller areas. So, but it's been shown that it's safe and effective to treat larger areas.
Right.
And people do get long-term relief.
Yeah, and that's true with both diagnoses that we went over today. How about your feeling? Do they need to stay on? Let's say they had seborrheic dermatitis and they clear up. Should they still continue using it? Let's say they had it on the scalp after they're clear, or should they stop and restart?
I tell patients to continue the medication. What they naturally do is try to cut it back, right? And they're doing it every other day for a while or whatnot to maintain it. And I think in the extension of the atopic derm study, the patients actually did it twice a week, 3 times a week, and they were able to maintain results. So yeah, can they cut back? But is it safe to use long term? Yeah, we have data to show that it's safe to use long term. And so it really controls that underlying inflammatory process like you were talking about.
Which is there. Another question which I'll address is, what about hair color or texture of hair? It wasn't a specific drill down, but in looking at people that did have colored hair that were in the trials, or changed their hair texture, they curled their hair when it was straight, there were no reports of changing hair color. And that's not true of some of the other agents that are approved by the FDA for seborrheic dermatitis. If you look at them, and there was nobody that said, this changed the texture of my hair, or it's not curly anymore, I just had it curled. None of that was reported in the trials that I'm aware of. So that was
there.
Important.
You go.
I think we're at the end, Ashish, but I'll go back and see if I don't believe we have.
There's one question, Dr. Delras. So
why is the product flammable? Right.
Well, yeah, you mentioned it already.
And so there are propellants in the canister. Basically contains the cream, but it's 65% water. The propellants are what put it into that foam, that physical characteristic of the foam. It's the propellants, when they are extruded out, with the foam, the propellants are what's flammable. And they immediately disappear into the environment. It's not the formulation itself. Right?
Well, that's the time we have to spend together. We'd like to thank again our Cutis Biotherapeutics for making this educational event possible. Thank you, Dr. Del Rosso and Dr. Ashish Bhatia, for very clinically practical information on this great treatment option. And also for all of you out there, if you want, you can join us for our next webinar. That's Tuesday, November 19th from 7 to 8 p.m. Eastern Standard Time, when we're going to talk about vitiligo real-world case studies with Dr. Heather Woolery-Lloyd. So thank you all so much for joining us this evening. Good night, everybody.
Thank you. It's great to see you.
Good night.
Thanks, Ashish. Thanks, Roxanne.
Great to see you.
Thanks, everybody.
Thank you both.
Take care.
Bye.
Have a good evening.
Bye-bye.
Bye-bye.